Welcome back guys. Now let's discuss about the collecting ducts. Guys, please concentrate here. What I am showing you in this pointed area, this area is the collecting duct. We have discussed about the proximal convoluted tubule, loop of Henle, distal convoluted tubule. Now we are discussing about the collecting ducts. See, this collecting duct, some part of collecting duct is present in the cortical region. See, here is the cortex. So some part of collecting duct which is present in the cortex is the cortical collecting duct, and the collecting duct which is present in the medulla. So this collecting duct is the medullary collecting duct. So how many collecting ducts are there? Cortical collecting duct and medullary collecting duct. These are the parts of a collecting duct. Simple. Now in this collecting duct, the epithelial cells, there are two different types of epithelial cells. What are the two different types of epithelial cells? Principal cells and intercalated cells. So principal cells and intercalated cells are present in collecting ducts. Okay. Now let's see what are the hormones which are acting on the collecting ducts. See, aldosterone and antidiuretic hormone, which is also known as vasopressin. Aldosterone and antidiuretic hormones, both these hormones will come and act on the collecting duct. How they are acting, why they are acting, what are the functions, we will discuss later. It's a simple. How many types of cells are there? Two different types of cells. What are they? Principal cells, intercalated cells. What are the hormones which are acting on the collecting ducts? Two different types of hormones. What are they? Aldosterone and antidiuretic hormone, also called as vasopressin. Now let's talk about the aldosterone. See, aldosterone, first of all, it's a steroid. Okay, it's a steroid. So why we are calling it as a steroid? Why? Because it is derived from the cholesterol. It's made from the cholesterol. So aldosterone is something, a mineralocorticoid. It's a mineralocorticoid, and it is produced from where? It is going to be produced from zona glomerulosa. Okay, zona glomerulosa. Glomerulosa of adrenal gland. Adrenal gland. Okay. See, we all know in the adrenal gland, if I show you adrenal gland something like this, we all know the adrenal gland was mainly divided into two parts, the outer cortex and inner medulla. Okay, this is the medulla and outer cortex. Now even cortex was further divided into three parts: the outer part, middle part and the inner part. Three parts. The outer part is this part. This part is the zona glomerulosa. The middle part is the zona fasciculata, and the innermost part is zona reticularis. Okay, something like, so you can remember it like GFR. Zona glomerulosa, zona fasciculata, zona reticularis. Now in endocrine, definitely we will study zona glomerulosa is going to produce aldosterone, zona fasciculata is going to produce cortisol, and zona reticularis is going to produce sex corticoids. Okay, and all of three are definitely steroid hormones which are made up of cholesterol, which are synthesized from cholesterol. So now our topic of concern is mineralocorticoid aldosterone. It's a mineralocorticoid. Why we are calling it as a mineralocorticoid? Why? Because it is associated with the mineral metabolism. Which mineral metabolism? Sodium metabolism. Okay, it's a mineralocorticoid which is coming out of adrenal gland. Now what it will do? See, this aldosterone, it will definitely act on the collecting ducts, we know. On which cells? It's going to act on principal cells, or is it going to act on the intercalated cells? It acts both on principal as well as intercalated cells. Principal cells as well as intercalated cells. Both the cells will act, and that function will be absolutely different. Now let's see what is the major stimulus for the release of this aldosterone. When aldosterone levels are going to be increased in the blood, what is that thing which will stimulate the release of aldosterone? It is hyperkalemia. Okay, the major stimulus is hyperkalemia. HYPER, hyperkalemia. Okay, so hyperkalemia is the one which stimulates the release of aldosterone. So from here, just logically you can think, so if hyperkalemia, increase in potassium concentration in blood, if it stimulates the release of aldosterone, what should aldosterone do? Aldosterone should come and decrease the levels of potassium. So that's what aldosterone will definitely do. So increase in potassium levels in the blood will stimulate the release of aldosterone. Aldosterone will come and decreases the level of potassium. How it will do, we will discuss, don't worry. So these are some important points about the aldosterone. Now let's see what are the functions of aldosterone. I have already said you aldosterone is something which is going to act on both principal cells as well as intercalated cells. Now if aldosterone acts on principal cells, what will happen? Now I said you this aldosterone is a mineralocorticoid, helps regulating the mineral metabolism. See, when aldosterone comes and acts on the principal cells, then these principal cells are going to reabsorb the sodium. So increases sodium reabsorption. If someone asks you what is the major function of the aldosterone, the main important function of the aldosterone is the sodium reabsorption. Don't say water reabsorption. It's not the water reabsorption which is most important. Sodium reabsorption is most important. If sodium is getting reabsorbed, just water follows the sodium. Okay. So as the sodium is getting reabsorbed, even water reabsorption will be increased. So increases the water reabsorption. Now, the same aldosterone, if it acts on the principal cells, helps in sodium reabsorption, water reabsorption, but helps in potassium excretion. It decreases the blood levels of potassium, decreases potassium, or I should say increases potassium excretion, not reabsorption, potassium excretion. Okay, so blood levels of potassium will be decreased. Now, what happens if aldosterone is acting on the intercalated cells? If it acts on the intercalated cells, these are totally different types of cells which are present in the collecting ducts. If it is acting on the intercalated cells, protons are going to be excreted, increases the proton excretion. Okay, so this is a basic flow chart kind of thing regarding the functions of the aldosterone. These are the functions of aldosterone. Aldosterone is going to act both on the principal cells as well as intercalated cells. If it's acting on the principal cell, mainly helps in reabsorption of the sodium and reabsorption of the water. And also the aldosterone will helps in excretion of the potassium. The same aldosterone, if it acts on the intercalated cells, helps in the excretion of protons. Protons will be excreted out of the body. Okay. Now, the same what and all we have discussed so far, let us see in a image format. You guys already know that, see, aldosterone, it's a steroid hormone. Now, if it is a steroid hormone, it's made up of cholesterol. If it is made up of cholesterol, definitely it can easily cross the cell membrane. So, remember for your entire life, all steroid hormones are those hormones which are synthesized from the cholesterol. So, all the steroid hormones, they can cross the lipid membrane, and these steroid hormones, they are having receptors inside the cell, not on the cell surface. See, most of the hormones are having the cell surface receptors, but these steroid hormones, they can cross the lipid membrane, they can enter into the cell, and even the receptor for these hormones is present inside the cell. So, it is intracellular receptors. The intracellular receptor can be intracytoplasmic or it can be intranuclear. That's a total different thing. But what I am trying to put into your mind is the steroid hormones cross the lipid membrane. They are having their receptors inside the cell. So, all steroids are having what type of receptors? Intracellular receptors. An intracellular receptor can be intracytoplasmic or intranuclear, anything. Now, let us come back to our discussion, topic of discussion, our aldosterone, it is a steroid, so it is coming into the cell. Now, inside the cell, it is having its receptor, it is going to activate its receptor, it is going to activate certain genes, a cascade of events are going to happen, but at the end of the day, what it is doing? When aldosterone is acting on the principal cell, see, it is helping in sodium reabsorption. So, aldosterone helps in sodium reabsorption. Now, the same aldosterone acting on the principal cell helps in potassium excretion. Potassium is getting excreted out of the cell. Now, along with the sodium, some amount of water will be reabsorbed into the body. So, water reabsorption also will happen under the influence of aldosterone, there is no doubt. Now, the same aldosterone, if it acts on intercalated cell, this is a total different cell. If it is acting on intercalated cell, what is happening? protons, okay, not potassium, protons are getting excreted. So in a simple way, what I can say is aldosterone, by acting on principal cell and intercalated cell, helps in reabsorption of sodium, reabsorption of water, and excretion of potassium and excretion of protons. Okay, so this is what the basic function of aldosterone. And from where aldosterone is coming? Aldosterone is coming from the zona glomerulosa of adrenal cortex. Now, what and all we have discussed? Let's see in a simple format, simple image. Aldosterone, can it cross the lipid bilayer or not? Yes, it can cross the cell membrane, and it's activating the receptor which is present in the cytoplasm. And at the end of the day, it's helping in sodium reabsorption, water reabsorption, and by acting on the principal cells helps in potassium excretion coming out. Now, let's see a few important points about the receptors. Guys, see, the intracellular receptors can be of two types: intracytoplasmic, intranuclear. I have already told you this. Okay, steroids can cross into the cell, they can cross the cell membrane, they are having the receptors inside the cell. Now, intracytoplasmic receptor, this is a repeatedly asked question, that's why I am just taking a minute to discuss this. So intracytoplasmic receptors, which means the receptor is present in the cytoplasm. Which hormones are using? See, glucocorticoids. What is the example of a glucocorticoid? Cortisol. So cortisol is also a steroid. Now cortisol, it's going to come into the cell, it's going to enter into the cell, it's going to bind its receptor in the cytoplasm. So glucocorticoids are having intracytoplasmic receptors. Mineralocorticoid. What is the example of mineralocorticoid? Our aldosterone, just now we are discussing, right? So aldosterone receptor is also present in cytoplasm. And even vitamin D. So glucocorticoids, mineralocorticoids and vitamin D, they are having intracytoplasmic receptors. Now if you talk to me about the intranuclear receptors, see, which hormones are using intranuclear receptors, which means these hormones will enter into the cell, into the cytoplasm. They can now even enter into the nucleus. Their receptor is present inside the nucleus. I used to have a mnemonic for myself, which is like sex with T3, T4, sex with T3 and T4. This is just a mnemonic which I made for myself. So what are those hormones? So sex steroids, so testosterone, estrogen, now they can enter into the cell, they can even enter into the nucleus, and the receptor for these hormones is present inside the nucleus. That's what I mean by. So sex steroids having intranuclear receptors, vitamin A is having intranuclear receptor, and T3, T4. Okay, thyroid hormones are also having intranuclear receptors. Keep this point in mind. Why we are discussing all this is because of this component. Okay, mineralocorticoid, aldosterone crosses the cell membrane, it's having intracellular receptor and also more specifically intracytoplasmic receptor. Now, two important terminologies I want you to know. Two important terminologies, the terms. You all know that aldosterone is going to act on the principal cells, helps in sodium reabsorption, water reabsorption and potassium excretion, you know it. But see, the channel, so this channel which is helping in sodium reabsorption, this channel is under the control of aldosterone or not? Yes, it is under the control of aldosterone. Aldosterone will activate this channel and sodium reabsorption is happening. What is the name of this channel? This channel name is ENaC or epithelial sodium channels. So direct MCQ, epithelial sodium channels are under the control of, their activity is under the control of aldosterone. If aldosterone is there, then only they will work, helps in the reabsorption of sodium. If there is no aldosterone, they won't function. So epithelial sodium channels are present on principal cells in collecting ducts. See, those channels which are helping in excretion of potassium, the name of these channels are known as ROMK. What is this ROMK? These are renal outer medullary potassium channels. So renal outer medullary potassium channels and epithelial sodium channels, they are under the control of aldosterone. Okay, so these two terms are important. Now, let's talk about a few important points about the epithelial sodium channels. I have already told you that epithelial sodium channels are under the control of aldosterone, no doubt. So let's write down here, the activity of ENaC means epithelial sodium channels is under the control of aldosterone, okay, which is our mineralocorticoid. Overactivity of epithelial sodium channel causes. Guys, remember, I have said you, whenever there is aldosterone, then only these epithelial sodium channels should have to work. Otherwise, they shouldn't work. Whenever there is aldosterone will activate the epithelial sodium channels. Sodium reabsorption happens, water reabsorption happens. When aldosterone level goes down, even the activity of the epithelial sodium channels should also have to go down. But because of some mutation in the genes, if epithelial sodium channels are continuously working, they are not controlled by aldosterone now. They are continuously expressing, they are continuously reabsorbing the sodium, they are continuously reabsorbing the water. So, what is this condition called as? This condition is known as Liddle syndrome. Okay, Liddle syndrome. So, Liddle syndrome is a condition where there is overexpression of epithelial sodium channels. I have already discussed with you. See, Liddle syndrome is the condition where ENaC means epithelial sodium channels are overactivated, overacting, they are overacting. So, what happens? See, now if this epithelial sodium channels, these violet color channels, if they are continuously working, they are continuously reabsorbing the sodium, they are continuously reabsorbing the water. If more and more sodium is getting reabsorbed in the body, what happens to the sodium levels in the body? The sodium levels in the body is going to be abnormally elevated, causing hypernatremia. So, Liddle syndrome patients are going to suffer with which condition? Hypernatremia. Liddle syndrome patients will have hypernatremia. Whenever you are having so much amount of sodium in your blood, that will cause hypertension. It's basic, right? So, hypernatremia and hypertension are the clinical features which can be seen in Liddle syndrome patients. As a doctor, how we can treat this condition? So, here by two ways you can treat it. The main way is, like, these channels are getting overactivated, right? They are continuously working, right? You can simply block these channels. You can block these channels. So, you can use a drug called as epithelial sodium channel blocker. So, what is the example of epithelial sodium channel blocker? The name of the drug is amyloride. Okay, so amyloride is epithelial sodium channel blocker which can be used in conditions like Liddle syndrome. Apart from this, you can also use drugs like aldosterone antagonists. Okay, we all know epithelial sodium channels are under the control of aldosterone. So, if you can block aldosterone, that will help us a bit in decreasing the expression of these epithelial sodium channels. So, you can also use drugs like aldosterone antagonists. Okay, so you can also use drugs like aldosterone antagonists, and one such famous drug is Spironolactone. So, Spironolactone is a aldosterone antagonist that can also be used. But important point is, repeatedly ask MCQ, what is the side effect of this spironolactone? The side effect of this is gynecomastia. Okay, increase in the size of the breasts. So, gynecomastia is the side effect of aldosterone antagonist like spironolactone. Now, here I just want to take a minute and I just want to relate this with the pharmacology way, because there are certain drugs which will cause gynecomastia, which is of highly clinical significance and exam importance. What are they? See, the mnemonic which is very popular is the DISCO group of drugs, DISCO. So, these DISCO group of drugs are going to have a side effect of gynecomastia. So, D for digitalis, I for isoniazid, S for spironolactone, which we have just discussed, and cimetidine and estrogens. So, usage of any of these drugs can have a side effect of gynecomastia. Keep that point in mind. Now, let us talk a few important points about the intercalated cells. Just close your eyes and just try to recall. When aldosterone is acting on intercalated cells, the intercalated cells will excrete protons. Protons are going to be excreted out. Okay, please concentrate, guys. Here, let me show you this image. See, in an intercalated cell, if aldosterone comes and act on the cell, protons are going to be excreted out. Proton excretion is happening. See, this proton excretion is going to be exchanged with potassium intake. So, what is this transporter doing? This transporter is throwing out the protons in return or in exchange for taking potassium in. So, can I call this as proton potassium antiporter or proton potassium exchanger? Yes, this is the exact MCQ they can ask you in exam. The proton excretion in an intercalated cell is mediated by proton potassium exchanger or antiporter. Okay, that's the MCQ. So let's discuss here. This is our intercalated cell. We know this is our intercalated cell. Now when aldosterone, if it's entering into the intercalated cell, what's happening? Potassium is taking in and one proton is getting excreted out. See, proton excretion is exchanged with potassium intake. So let's write MCQ in intercalated cell here. In intercalated cell, proton excretion occurs via proton potassium exchanger. Okay, later I will be discussing with you, there are two types of intercalated cells, type A intercalated cells and type B intercalated cells. Just for now, remember, so these are type A intercalated cells, type A intercalated cells. Just remember like this, type A for acid excreting. See, protons are nothing but acids, right? So acid excreting intercalated cells are type A. Okay, base excreting are type B. At the end of the lecture, we will discuss what exactly are type B intercalated cells and functions. Just for now, aldosterone acts on type A intercalated cells, helps in proton excretion exchanged for potassium intake. Now let's discuss about a condition called as Conn syndrome, C-O-N-N-S, Conn syndrome. What exactly is Conn syndrome? Because of some tumor in the adrenal cortex, there is too much production of aldosterone. So much amount of aldosterone is there in the body. Now what happens in this condition? In Conn syndrome, yes, we know there is so much amount of aldosterone. If there is so much amount of aldosterone, this aldosterone is going to act on the principal cells. So what happens? What happened to the level of sodium? You just think and say, normally aldosterone helps in sodium reabsorption, water reabsorption and potassium excretion. Now whenever there is so much amount of aldosterone, what happened to the levels of sodium in the body? Yes, you are thinking that sodium levels will be elevated. But interestingly, here in this condition, sodium levels most of the times will be normal or slightly elevated. Okay, so normal or slightly elevated. Why the sodium levels are not getting so much increased, that we will discuss. There is a phenomenon called as aldosterone escape. Even though there is so much amount of aldosterone in the body, the sodium levels are not going to be raised. Why? Why? Because of a phenomenon called as aldosterone escape. In a few minutes we will discuss that. Now, let's come back to our normal discussion. What happens if there is so much amount of aldosterone? Sodium levels will be slightly elevated or normal. What happened to potassium? Normally aldosterone throws the potassium out of the body. Whenever there is so much amount of aldosterone, so much amount of potassium is going to leave the body. So what happens? Potassium levels in the body is going to be decreased. That will cause as hypokalemia. Okay, that causes hypokalemia. Now what happened to the protons? Normally aldosterone throws the protons out of the body. Whenever there is so much amount of aldosterone in Conn syndrome, so many number of protons are going to excrete it out. So when so much amount of protons are going out of the body means, will this person have alkalosis or acidosis? All the protons, all the acids are leaving the body. So the person will have alkalosis, metabolic alkalosis. Okay, because the proton levels in the body are going to be decreased. Now let's discuss what exactly is this aldosterone escape. Why in Conn syndrome, even though there is so much amount of aldosterone, why the sodium level is not getting increased? See, it's because, yes, in Conn syndrome, aldosterone levels increase. There is no doubt. Because of the adrenal adenoma, adrenal gland tumor, so much amount of aldosterone is coming. There is no doubt. Now, this aldosterone, yes, it increases the sodium reabsorption. It acts on the principal cells and increases the sodium reabsorption. No doubt. When lots and lots of sodium is being reabsorbed and lots of sodium is kept again into the body circulation, what happened to the sodium levels in the body? There will be hypernatremia and that increases the BP. Yes. Now, Whenever there is hypernatremia, we all know wherever there is sodium, water will be attracted towards the sodium. In the blood, so much amount of sodium is there now. So what happens from the tissues, from the cells, water is getting pulled, water is getting attracted towards the sodium. So from all the tissues, from all the cells, water is getting entering into the blood, or water is going towards the sodium. So what happened to the blood levels? What happened to the extracellular fluids? Extracellular fluid is nothing but your blood. What happened to the blood volume? The blood volume increases, extracellular fluid levels increases. Now if lots and lots of blood is there, what happened to the venous return to the heart? So all this extra amount of blood is coming to the heart, right? So venous return to the heart increases. If venous return to heart increases, the amount of blood reaching your right atrium also increases. Your right atria will be stretched because more volume of blood is coming to the right atria. So right atrium is now getting stretched. Now this right atrium is sensing, oh my god, there is fluid overload, so much amount of blood is coming. Now what your atria will do? Now the atria is going to release atrial natriuretic peptide. Okay, now the atria are going to release something called as atrial natriuretic peptide. The name itself is a natriuresis. Sodium should be excreted in the urine. So this atrial natriuretic peptide will come and act on the nephron and increases the sodium excretion. So whatever the extra amount of, please concentrate here, whatever the extra amount of sodium which is getting reabsorbed under the influence of aldosterone, all that extra sodium is again getting excreted because of atrial natriuretic peptide. This is known as aldosterone escape phenomena. So what is the importance of aldosterone escape phenomena? Even though under the influence of aldosterone, if there is so much amount of aldosterone, so much amount of sodium is getting reabsorbed, but all that extra reabsorbed sodium will be again sent back into the urine with the help of this atrial natriuretic peptide. So abnormally sodium levels will never increase in the blood. Okay, so can we say aldosterone and atrial natriuretic peptide, they are absolutely antagonistic hormones? Yes. So aldosterone will try to reabsorb the sodium, atrial natriuretic peptide will excrete the sodium. So they are physiologically antagonistic hormones. Okay, now in the last slide, I just want to highlight point. See, whenever there is increased aldosterone levels in the body, something like a Conn syndrome, yes, reabsorption of the sodium will happen. More sodium will be reabsorbed, more water will be reabsorbed. That increases the extracellular fluid volume. When extracellular volume is going to be increased, the blood pressure will be increased. The atria are receiving more and more blood. There is volume overload to the atria. Now atria will release the atrial natriuretic peptide. This atrial natriuretic peptide will help in excretion of the extra sodium and that water in the urine. Okay, so this is aldosterone escape. Hope the concept is clear. Now in the next video, let's discuss about the antidiuretic hormone. We have discussed how aldosterone is functioning. Now let's discuss about how antidiuretic hormone is going to act on the body. Thank you.